All right, Lynette, shall we?
We shall. Aloha. The CME activity is jointly provided by the Queens Medical Center and UH-Jabson Department of Geriatric Medicine. Just a reminder, please complete the evaluation forms for attendance. These are required to receive CME credit. Enter the name and credentials of everyone viewing this geriatrics ECRO. You can find the evaluations by following the link in the chat or at any time on your website, on our website, or email advertisement. We offer free continuing education for this series after you have completed your evaluations. Certificates are emailed the Monday after our educational series. Your comments are very important to the planning committee and will be used to plan future programs. About ECHO, we want to remind everyone that this is an ECHO webinar, which means that this session serves as a forum for mutual teaching and learning from experts and from each of us on the front lines. As the ECHO model goes, all teach, all learn. So it will take all of you to create this community of learning. A little bit about our format. After a short lecture from our experts, we will share expertise from the rest of the team and then open the time up for case discussions. We invite you to share any geriatric cases. It may even be on a topic not related to today's lecture. We only ask that you keep the case for discussion HIPAA compliant. That means please do not share patient's name, birthday, address, and so on. We learn best from our patients. They are our best teachers. Our interdisciplinary team is here as well, and we are all willing to teach and share our collective wisdom with you. Most of you already know me. I am Lynette Gaylord, president of ARCA, Care Home Operators Association, Mary Boltan, president of Adult Foster Family Home Association, Juliana Caldwell from Aloha Care, Leila Ventar from United Healthcare, Dr. Aida Wen is our special speaker today, and Dr. Rita Bell Fernandez from University of Hawaii. Prior to last month, we finished a 4-month series on mobility. And last month, we started our 4-month series on medication, starting off with psychotropic medications. If you're interested in viewing any of those lectures, you can find them on our website. Unfortunately, we cannot offer certificates of attendance for videos you have viewed. You must participate in our education live. This month, we will be talking about managing pain with medication. It now gives me great pleasure to introduce our speaker for today, our own Dr. Aida Wen. Dr. Wen is an associate professor, Department of Geriatric Medicine, John A. Burns School of Medicine, JABSOM, at the University of Hawaii. She is the program director of the Geriatric Medicine Fellowship Program. She serves as the medical director at a nursing facility and is the president and founder of the Hawaii Medical Directors Association. That was since 2008. She is board certified in geriatrics and palliative care. She is also a consultant for Aloha Care Health Plan in the Division of Long-Term Services and Support. She is currently the PI for the Geriatric Workforce Enhancement Program, WEP. Through her role in several educational grants, she has developed a wide network of collaborators, partners, and community stakeholders and caregivers who care for our elderly population, and is a strong advocate for improving geriatric and dementia care, striving to help patients and providers help seniors age as gracefully as possible. And now, Dr. Wen, take it away.
Oh my goodness, thank you. That was a long introduction. I have to shorten it sometime. Okay, anyway, let me share screen here. Okay, can you all see that? Yeah, so this is just a little bit of, January, February, March, April. We've been talking a little bit about medication safety, and today we're doing managing pain. All right, let's see. But before we do that, I'm here to provide another COVID update. I know we're tired of COVID updates, but here is another one. Actually, it's hot off the press. 2 days ago, the FDA made an announcement, and here's the reference if you want to go check it out yourself. It's fda.gov. And what it basically says is, you remember the original COVID vaccine that first came out in December of 2020? That seems like ages ago. Anyway, 2020, when we had the original one, you know what? It's no longer authorized. So we can just let it go by the wayside. The new vaccine now is the current bivalent COVID-19 vaccine. That is, it actually has components of the original vaccine, plus it has pieces of the BA4 and BA5 strains, and that first came out in September 2022, 6 months ago. So that is the current vaccine now for COVID. And it is now authorized for all doses going forward with simplified schedules because the old one is no longer going to be authorized. And we still encourage you to get it because protection means less severe disease, less hospitalization, and less death among our nursing home and care home residents. So can we get it now? Yes. So older adults who are 65 years and older who have already received that single dose of the bivalent, say if they got in January, it's now April. They can receive one more dose, at least 4 months following their initial bivalent vaccine. So if you started back in September when it was first introduced, you are clearly, more than 4 months out. You're like 7 months out. So it's good. Go ahead if you can do that. That would be great. Who else can get another dose of the bivalent vaccine? People who are immunocompromised or have received if you're immunocompromised, you can get it sooner than 4 months. You can get it after 2 months because your vaccines aren't as effective. So yeah, so those people can get it within 2 months of their last vaccine. And people who have previously received a monovalent original vaccine and did not yet receive their first bivalent, they can go ahead and just go ahead and get it at this time. And then unvaccinated people may receive 1 dose of a bivalent instead of going back to the original vaccine and getting, remember that the 2 doses of the booster and all that's complicated regimen. Is very simple. If you didn't get the original monovalent vaccine, then you can just get the 1 dose of the bivalent and you're good. I think there's another common question, which I just received, but it's not on the slide. What if you got COVID? So if you got COVID recently, you've got antibodies that your own body has manufactured, and they're probably good for at least 90 days. So that's 3 months. And so you actually don't need to get the bivalent booster until after 3 months. So I hope that is not too confusing. Okay, who cannot get the next dose of the bivalent? So people who have already received the single dose of the bivalent and are not over the age of 65 and are not immunocompromised, you guys have to wait. And that's, most of the population. So, but the FDA is going to make decisions about a future vaccination in June of 2023 after they review the information about the fall strain of COVID. So they're actually looking at all this, the data now, and they're looking at the new variants right now, and they're going to decide whether or not they're going to create a new vaccine instead of so that you can take that one instead of that will be the most updated. So basically for everybody else can wait, a big wait button there. And then this is just to say that vaccine schedules for children are a little bit different, but I'm not going to go through it today. I'm just going to point you to go to fda.gov and you can read it on your own. It's kind of lots of words there. But the most important thing I want to convey is that all residents who are eligible should get the bivalent booster shot before the public health emergency ends on May 11th, 2023, if possible. If you can, because basically that's when it's free. And after that, you're just gonna hope that the insurance companies will cover it. Otherwise it's out of pocket because that's what ends, the public health emergency ends on that, and the government is not going to be supplying it for free anymore. So yeah, sign up, get your residents signed up to get their booster shots if they can get it. Any questions on the COVID stuff? Everybody's good? All right,
I think we're good. Thank you.
Great. Yeah, type questions in the box, chat box if you happen to think of any. Okay, now we're on to medication safety, managing pain. So this is just a quick review. So a lot of adults are taking too many medications because they have too many medical problems, and all medications have side effects and interactions, and it's hard to swallow and challenging to take them all correctly. So that's why we need to reduce the number of medications and only take the ones they absolutely need to. And the other problem is in older adults, the reason why we want to trim down the medications if possible is because the kidneys and the liver don't work to eliminate the drugs out of your system as readily as they did when you were young. So we have to really try to minimize medications if we can, and also watch out, especially for drugs that increase the risk for falls, confusion, dehydration, low blood sugars, or bleeding. These are the high risk medications, right? And those are listed in what's known as the Beers criteria. And so this medication safety series, which in the last 4 months we've been covering, our goal is to make sure that you are aware of these high-risk medications. So you, all of you who are on the front lines every day, can help us monitor safety and work together with the doctors to reduce their use and prevent bad events, because that's what we see in the emergency room. And so we covered some of these problem medications, right? And the thing that these medications have in common is that they're mind-altering drugs, right? They work on causing they have problems with causing sleepiness, poor appetite, and falls, and everything like that. So don't be afraid to ask the doctor if all these medicines are necessary and if there are things you can do to minimize the use of these kinds of drugs. Okay, so here's a little quick case scenario. It's Mrs. C. She's an 82-year-old woman. Maybe you know her, right? She's constantly complaining of aches and pains everywhere. She has a history of gout. She has shingles on her left shoulder. She has arthritis on her knees. She has osteoporosis and kyphosis, which means her back spine is collapsing and she's bent forward. And she has constipation. Anybody know this lady? I think we all do, right? She has trouble sleeping at night, and she doesn't want to get out of bed in the morning. And she has to take sleeping pills every few days. She asks for Tylenol every day, but she says it doesn't really help her. She wants to try oxycodone because she took it a few years ago after her hip fracture, and it worked really well back then. What should you do? Should you say, you know what, good idea, let's go ask for some oxycodone? Is that what we should do? Okay, well, first thing we should do is we should think about, well, let's characterize, oh yeah, osteoporosis workup. Yes, good idea. Yeah. Other things. No? Okay, side effects. Yeah, that's what we're going to be worried about, right? If we say, okay, oxycodone, now we're going to have to worry about side effects. So we have to think about this a little bit more. All right, so how do we think about pain? Well, here's a tip. First, we have to think about what type of pain is this, right? Not all pain is the same, right? Some pains are more muscle and joint pains, right? That's what we call somatic pain. And that's characterized by aching, it's sore, it's sharp, those kinds of things. And that's the kind of pain you see with arthritis. And if you've had fractures, you have low back pain, that's the kind of muscle and joint pain. There's another type of pain that this woman has, right? It's nerve pain. And nerve pain is different. Nerve pain comes from injury to the nerves. And the most common ones can happen with people with diabetes. Long-standing diabetes can have nerve pain. People who have post-stroke, people who have had shingles, right? Those kinds of things. Or sciatica, those kinds. And what that kind of pain is, it's really kind of different. It's burning, it's tingling, it's shooting, and it comes and goes whenever it wants. You don't even have to touch it and it'll suddenly come and go. So that's nerve pain, which is very different. And then there's another pain called visceral pain. And basically visceral pain is things in your body that fill up and stretch, things like your bladder and your stomach and your colon, and they cramp. So things that have crampy and if sharp crampy pains, that's visceral pain. So, and one big example is constipation. So if you're constantly getting constipation and then you take medicines to relieve the constipation, you get really bad cramps, right? And that can last for a bit. So those are the different types of pain that would be helpful to characterize, because different pains are treated differently, right? You don't have to throw oxycodone to everything. And then another type, then the other way to characterize pain, is it acute or chronic? So acute means that it starts suddenly, and it usually happens due to a disease or an injury or inflammation. So it's important to get a diagnosis and to treat the underlying cause. And if you don't treat the acute pain, sometimes it can turn into a chronic pain. So what's an example of acute pain, right? Fractures. If you fall and you break a bone, yeah, that's acute pain. It's sudden, it started suddenly. And surgery too, right? You just had a knife, right? Cut part of your body, right? That's sudden pain. Okay, and chronic pain is pain that lasts a long time, and the pain continues beyond the normal time of healing. So you would think that after a fracture and it's 8 weeks later, they should be over it by now, right? But if it's going beyond that, then that's called chronic pain, and it can cause severe problems that impact function. A common one, is arthritis, just for example. And the other way that's important to describe pain that's really helpful, especially when you're talking to doctors about, getting them pain meds, is how much pain are they having, right? Have you guys ever heard of that Facey's pain scale, right? You see all the happy faces, sad face, you kind of go along there. Nice idea, but actually we don't recommend using it because it can kind of be confusing. You might think it has to do with mood and not necessarily pain. So are you happy? No, I'm not happy. Are you sad? Yeah, I'm very sad. But is it because of pain? Who knows? Maybe not. Maybe they're just sad because they're lonely. So generally, they use it for children, but I don't know. I think it's kind of confusing for older adults. The number rating scale is also kind of confusing for a lot of people because it's abstract, right? What does 1 mean? What does 2 mean? Is that pain? How does that correlate with pain, right? If you try to ask a toddler on a scale of 1 to 10, what's your level of pain? They're going to look at you funny, right? Like, what are you talking about? It's pain. It's not a number, right? So when you talking to people with some level of dementia, this concept is very abstract. So really the best thing to do is to just describe the pain, right? Everybody understands that. You say, hey, is this the worst pain you've ever had? Does it hurt a lot? Or is it not hurting at all? Or just does it hurt a little bit? Does it hurt kind of medium? Or does it hurt a lot, but it's not the worst? Can you bear it? And so if you describe it, that's a verbal descriptive scale. And that's probably your best bet of understanding how much pain it has and how much it's impacting you. Does it hurt so much that you're not able to stand? Does it hurt so much that you can't get out of bed or you can't sleep? That's kind of a functional descriptor scale. But yeah, describing it is probably the best way of getting at pain assessment. Okay, what about strategies for pain management? So there's lots of different ways. Non-medication strategies are always what we try first. And then there's non-opioid medications, that's non-narcotic, and you can get it over the counter, stuff like Tylenol and ibuprofen, right? And I'll explain a few more in the next slide or so. And then there's the opioid medications, which is the narcotics, which is the one of last resort. So I wanted to just go over some of the other strategies that we really need to think about and encourage people to use. So lots of non-medication strategies. Hot and cold packs, they're actually quite effective. For some people, they really do really well. So I would say, I mean, even if post, after surgery or after you fell and you had a bad bruise or you twisted your ankle, right? You get a cold pack, right? And it really helps. So that's helpful. Massage therapy can be very helpful too, especially sometimes after an injury, after a fall or something, and you tighten the muscles, tighten up, right? Massage therapy can be helpful. Some people find acupuncture and chiropractic helpful. There are biofeedback techniques, which are a little fancier. There's the transcutaneous electrical nerve stimulation. That's as short as TENS. I don't know if you've heard of TENS. And basically is you just basically put a little electrical stimulation on that area of pain and stimulates the nerve a little bit, and it helps reduce the pain in the area. Usually those are kind of administered by physical therapists. There's surgery actually. If then surgery and nerve blocks can also reduce pain, right? Sometimes if you've got cancer or something like that, you want to block the nerve, and then you can use less medications. And surgery, of course, is, if you have a tumor, you want to remove it so it won't obstruct or whatever it is, right? A little bit more definitive treatment. There's physical therapy and other rehab services to help with function and pain. There's psychotherapy for the chronic pain people, because there's oftentimes, it's not just pain. I mean, the pain causes impacts on your mood and depression and everything like that. So sometimes trying to help reframe the pain and trying to move past it is really critical for getting back to living, for functioning. There's meditation. There's even dietary types of interventions. That's usually not immediate, but things that are anti-inflammatory or things like that. Okay, what kinds of over-the-counter things can we get? Well, there's acetaminophen, good old Tylenol. Always try that. You never know. There's some people who are really responsive to. I've had people, after surgery, hip surgery, and they just do fine on Tylenol. They don't really need anything else. And, trying to give them more is just causing more side effects. So give it a go first. And even if it's not completely reduced, completely gone, it may reduce it enough that you may need a lower dose of other medications. The NSAIDs, the non-steroidal anti-inflammatory drugs, are the things like ibuprofen, and you may see them in the drugstore as Advil and Motrin. And there's naproxen, which you see in the store as Aleve, and things like aspirin, right? And have you noticed that there's also a whole shelf full of topical skin products, right? So the topical things like diclofenac gel. So it's basically one of the anti-inflammatory drugs in gel form, and that you rub it right into your joint or into the muscle over there, right? And it's best if the pain is not deep, and that could be used for that. There's capsaicin cream, which is actually derived from chili peppers. So don't rub your eyes after you apply it. But yeah, so that can be applied, and there's different strengths to whatever parts of the body or joints that hurt. That can also be gotten over the counter. And there's even lidocaine gel, which you can buy over the counter as well. And you may find these in things like Salon Pass, Icy Hot, or Aspercreme. These are all familiar to you. But you have to look to see if that formulation, that patch, has with lidocaine gel. Okay. Sometimes it has, with other things in it. So you got to look at those side ingredients, but those things do exist over the counter and can be tried, and you should talk to the doctor about that too. What else? So there's more non-prescription, there's more non-opioid medicines that are prescribed by the doctor. And actually it turns out, so the Voltaren gel that you can get over the counter, you can actually get a prescription for that too. And there's other NSAIDs other than ibuprofen out there that the doctors can also give you to try that may have fewer side effects. And look at this, antidepressants, right? Look at that, duloxetine. So some antidepressants can help with nerve pain. So if this is a person with nerve pain from shingles or something like that, then yeah, it's probably helpful to try duloxetine or some tricyclic antidepressants, and can help reduce nerve pain. Now, interestingly, there's anti-seizure medications too. Those help calm down nerves from firing, right? And that helps with nerve pain too. So stuff like gabapentin, which you may know as Nervantin, or pregabalin, which you may know as Lyrica, and lidocaine patch, right? These are medications that reduce seizures. And so if your nerves are just damaged and they're firing and they're like fritzy, right? Then you want to do anti-seizure medicines, and that will help a lot more than any opioid or Tylenol or things like that you can prescribe. So we really need to characterize that pain. Capsaicin patch is also available as well, not just as cream, but the patch one has to be prescribed and applied in the doctor's office. Okay, so, and then finally, we're gonna just get to opioids. So why do we want to avoid opioids, right? What's the problem with opioids? Addiction, right? It's addictive. What else? It can cause drowsiness, confusion, forgetfulness, difficulty talking. You've seen people, right, who are drugged, they got slurred speech, right? Or they have trouble swallowing. And I'll tell you, I've seen people admitted to the hospital with aspiration pneumonia after starting an opioid because they just got a little bit too sleepy. They drank their water or drank their whatever juice and it went down the wrong pipe. Accidents. So it's a mind-altering drug. It can cause accidents like drunk driving, just like drunk driving. So don't go driving if you have, right? Or don't operate heavy equipment, or don't do, or even walking without a walker, right? It's like you're walking drunk, right? Falls and hip fractures, of course, and it's worse if you're combining it with benzodiazepines, which are anti-anxiety meds, or sleeping pills, or alcohol, right? And we just read about this lady, Mrs. C, who takes sleeping pills sometimes because she can't sleep at night, right? So that would be bad if we did that in combination. And what else? So, well, what is overdose? Overdose looks like they're hard to wake up, or they're unconscious and you're trying to shake them, right? Shake them awake. Their heart beating is very slow, or the heart might stop. Blood pressure might drop, and the breathing rate becomes slow and shallow, or it might stop too. And so that's dangerous, and people die from opioid overdose. And we've heard stories of that in the news plenty, right? All those fentanyl drugs, right? And opioid overdoses. And so, and our older population, they're not metabolizing these drugs very rapidly. Their kidneys and their livers are slow. So that's just going to accumulate. So we really need to try to avoid these opioids as much as possible. Or if they are getting it and they do get overdose, we have to have a plan what we're going to do. So hopefully you've heard of naloxone nasal spray. That is the new thing here. It's a Narcan that is administered by nasal spray. So you can just pick it up and you squirt it in the nose, right? So if you find somebody who's not waking up and you think, you know what, they took a little too much of the opioid and they're not waking up and they're breathing slow, maybe start CPR if they've already stopped breathing or their heart has stopped, and give the naloxone one spray into one nostril, then call 911. And then you can repeat it if you like. This spray only lasts about 30 to 90 minutes, doesn't last forever. So hopefully you have gotten 911 over, the ambulance paramedics have come. The thing about this anti-opioid, this naloxone, is that it's the reversal of opioid, and so it's going to cause withdrawal symptoms, and withdrawal doesn't feel good either. So you're going to have nausea, vomiting, sweating, muscle pain, aches, and things like that. But it's better than dying, I guess. So, but you know, think about it a little bit. If you give too many doses of naloxone right away, you may give them really severe withdrawal. So how do we get naloxone? So you can get a prescription. So if you get an opioid prescription, you can say, hey, can I also have a prescription for naloxone at the same time, just to have, just in case. Or you can actually get it over the counter. So a little, like less than 1 month ago, in March 29th, the FDA approved over-the-counter Narcan. So you can actually go to the pharmacy and buy it over the counter without a doctor's prescription, because that's how much they want to prevent opioid deaths, is that they've made this thing over the counter. Okay, so what else? We need to think about how to using opioids safely. We have to find out who is at risk. So one thing we can do is use this opioid risk tool, which I'll show in the next slide. How else? We have to start low and go slow. So if we're going to start an opioid, don't give the full dose. Give half a tablet maybe, and say, test it out and see if they're tolerating it, right? And don't use long-acting opioids for people who have never taken opioids before. And then after every dose, you should monitor for sedation, confusion, falls, constipation, things like that. So you have to monitor, and if you're seeing these side effects, you need to stop and go back to the doctor and say, hey, I think maybe too much. Do we have another strategy? They may lower the dose or give another strategy, another adjunct. Okay, here is the opioid risk tool, which we should be aware of before we start people on any opioids. We need to think about, okay, are they at risk for addiction? So this is sort of the little table, so you can ask yourself, oh, so do they have a family history of substance abuse? Do they have a personal history of substance abuse? Are they between the ages of 16 and 45? That increases your risk. If they have a history of pre-adolescent sexual abuse, that increases your risk quite a lot, actually, by 3 points. And then any other psychiatric disease or even depression can increase your risk for opioid abuse. So if you have a score between 4 to 7, you have a moderate risk for opioid abuse, and then you need to, of course, 8, you have a high risk, and then you really need to have second thoughts about prescribing opioids. If you're lower than that, you're probably just looking at trying to monitor the side effects. But above that, in the range 4 to 7 and higher, you need to probably put extra precautions in place. Okay, so let's go back to Mrs. C. So what were we going to do with her? Where are we going to start?
Start slow.
Start slow, right? Start low, guys. Are you jumping to opioids already? Or you, what do you mean by start slow?
Oh, with any medication.
Yes, with any medications, right? Okay. So I'm just going to start with this. So let's characterize her pain. What types of pain does she have, right? She's got all these different types of pain, which means that we should probably try to address different pains differently. So we have a strategy, right? Oh, I have a question here. Yeah, okay. Ask the resident how her pain is. That's a great idea, right? You have to ask them. And what are you going to ask them about? How bad the pain is? Yeah, right. And so the thing is, right? So good question. Here's the answer. So she says her knees She doesn't have any pain in her knees when she's resting, which is why she doesn't get up. But the pain is moderate, so it's 5 or 6 out of 10 when she stands or walks. And her back is pretty bad, and it's worse with position change, and it's worse at night. And the shingles is kind of mild. She's been living it for a while, and it's 3 out of 10. It's just minimal. It doesn't bother her that much. And what's her constipation like? It's moderate, it's uncomfortable. She sometimes has a BM like every 3 to 5 days, which is not ideal for her, especially when it heads to the 5-day mark, right? And let's see, how much does it impact her? Well, she doesn't walk anymore, right? Because she'd rather sit down. So she doesn't want to especially avoid walking long distances. And the pain that bothers her the most is her back pain at night. The shingles is just annoying. And the constipation is just intermittent, especially due to cramping and diarrhea. So, okay. Oh, look at this. We have some really good comments here. Family history, is that just immediate family members? How extended? Well, I think more immediate is probably the most bang for your buck. I mean, you probably could go longer, but I think the immediate family history is the most for the opioid use and the so yeah, we need to get all this information so we can report it to the doctor, right? How bad is the pain before and after certain activities, I think is what you mean, right? And some residents have a hard time explaining the pain levels. So that's what we were talking about, the tools. So, interestingly here, when I say moderate is 5 to 6 out of 10, I don't actually ask, sometimes I ask the patients for the number sometimes, but usually I just give them the verbal scale. I say, hey, is it bad? How bad is it? It's kind of medium, and how does it affect your function and things like that. And then based on what they tell me, I say, okay, it sounds like it's moderate pain. It's probably on the order of 5 to 6. So I translate it back for them. Instead of asking them for the number straight up, I ask for the level of pain, describing the pain and how bad is it. I mean, you don't want to be chasing pain that's really minimal and doesn't bother them, right? You want to treat the one that impacts them the most, the one that's the worst. And for someone who's nonverbal, yes, right? We want to look at body language. So you're looking for grimacing. Yeah. We're looking at the face and say, and so sometimes when I'm moving their arm or their leg, I look at their face. I don't look at their arm or their leg. I look at their face. And if I see a little bit of a wincing or closing the eyes or the tensing of the muscles or even the body language, if it kind of tenses and guards a little bit, then I know that, okay, they are saying it's not painful, but their body language is showing it's definitely painful, right? So that you have to take into account as well. So yeah, body language is very important, especially for people who are nonverbal. And then when in doubt, right, you just give a little Tylenol trial and see if that helps. Okay, so Renata is saying her depressed immune system is probably contributing to her pain. Immune system depression due to shingles reactivation, not moving much, things like that. Yeah, so that's why we say sometimes that diet, like, decreased inflammation, decreased that kind of thing may help. And definitely shingles is reactivated when an immune system is depressed, right? That's immunosuppression. Okay. All right. So let's see. What are we going to do with this woman? So, so how much, the really important, it's not just how much pain they have, how much does it impact them, right? Is really important. And from looking at this, I'm going to spend my time thinking about, I think I should address their worst problem first, which is back trouble that prevents her from sleeping at night. Yeah. I think let's do that first. And then maybe we'll address some of the others later, right? So we could do that. That's good. Yeah. So great. So you have great doctors, right? Who prescribe Tylenol on a routine basis. So that's what I do too. Sometimes if I'm not sure and they have this grimacing, or if they're having trouble sleeping at night, they're nonverbal and they're a little restless, first thing to try is, well, maybe they have like just aching, pain, and just can't figure out what it is. Well, just some Tylenol and see if it helps. Sometimes it does. If not, then, we got to keep on looking, but sometimes we don't know. And sometimes it was just that mild, low level pain that's causing just enough discomfort to prevent them from sleeping at night. So always try that first, because it tends to be the least side effects, as long as they don't have liver disease. And of course, there's a maximum dose. So what else could we do? So here are some ideas. Maybe try lidocaine jelly, topical cream, lidoderm, capsaicin, Salonpas, right? Can try that, right? On her knees, on her back. Can try that to go to sleep at night instead of, it's amazing how many people take sleeping pills to treat pain. They say, oh, I can't sleep at night, and then they take sleeping pills. I'm like, well, that won't, yeah, it'll help you sleep, but it actually doesn't address the root cause. So yeah, so we try that, try to address the underlying cause. So like standing doses of Tylenol, or consider a hot pack at bedtime, right? Maybe just do a little massage down in the lower back or wherever it is that's bothering her. Try that. Or, maybe even consider tramadol, which is not quite an opioid, but sort of is an opioid. Yeah, diclofenac, that is Voltaren topical. That, yep. Sometimes just I use that, and if it's a very targeted area, just try that. So yeah, maybe for her, that's enough for the nighttime, right? Or for her knees, those are good. And yeah, so maybe the diclofenac gel for the back. And if she has shingles, you can do the lidoderm patch for the shingles on the left shoulder, because lidoderm is really good for the neuropathic pain, right? So a different patch for a different part of the body, because it's a different problem, right? And of course, you want to avoid opioids, and maybe try just to, get her on a standing dose of bowel regimen, because you really want to avoid the opioids, because she already is going every 3 to 5 days. And so if you do, you might want to also start something like Miralax or Metamucil or something like that. Right. Okay. So yeah, so this is the opioid risk tool, right? So we can do that for her too. And of course, we found out that maybe she has a family history of alcohol, and she has her own history of depression, but she's only a score of 2, so she's not really high risk. So that's good. So we can feel a little bit better about that. What if she was at high risk? What would we do differently? Well, I would probably start, well, we have, you have to let the doctor know. And then the doctor can actually go online. There's like this opioid drug registry that every doctor and pharmacist can check, and they can look at the history of opioid shopping. Some people, they get, a little bit from this ER and a little bit from that urgent care and a little bit from their primary doctor, and then they can have an accumulation, right? And they can sort of see that history in this this tool. So definitely checking on that. And sometimes we do like a contract with patients who are at high risk. It's not to say that we're not giving it to them. We're going to give them smaller amounts, and we're going to monitor it. And we have to they will have to agree that they're not going to get it from any other place except them. And of course, we'll check the background and everything. So And then sometimes, if so you kind of keep them on a short leash. Okay, and as Jomel said before, right? Start low, go slow, right? Start half a tablet, maybe at bedtime, and then adjust the dose every few days based on their side effect. And like don't use long-acting drugs for folks who have never used opioids. And then monitor, keeping track. Well, let's keep track of her sleeping, let's keep track of her. Is she too tired to go to activities? How's her BMs? Is it now every, 7 days instead, So get it, look, make sure you monitor closely. Okay, and then of course, then, she's very happy after you've given her good treatment. So anyway, so I'm gonna stop share and I'm gonna, if people want to talk about their challenges, let's see if we can all help out. I'm sure you have residents who have aches and pains. Don't be shy. It's okay. We've all had crazy, complicated. Yeah. Recommend having naloxone at home as a precaution to overdose. I think it's a good idea. You may never need it. You may never use it, but you can get it over the counter and just have one dose of it around, just in case. You never know. There are accidental ingestions as well. So you want to have that as a precaution. Oh, somebody uses a gel ice pack. Yeah, ice packs are really helpful. I like to do that too. Ice packs are good and hot packs are good, right? It depends on the person. And some people, if it's an acute injury, then ice pack. If it's a chronic pain, then oftentimes a little warm pack might be helpful. And what else do people do when you have a resident who's always complaining of pain? Water therapy. Tell us about it. Renata, I want you to tell us about it. What do you do? Do you want to share? Swimming pool exercises. Yeah, if you have access to that.
Does that include Epsom salts? Epsom salts in a bath?
It can, yeah. Especially, I suppose, you know what I'm thinking, especially if your hands are arthritis, you can put it in a small bath, yeah, and do that. If it's your whole body, I'm not sure, so you need a big pool, but you've only been to one care home that has a pool, yeah. But if they have arthritis in the hands, maybe they can just do a hand thing, right? Sometimes that helps, a warm bath. What else? What else?
I always ask my doctor if we can just do routine Tylenol. That usually works. That's my best suggestion.
Yeah, I agree. How about deep breathing? Do you guys recommend deep breathing with your residents sometimes? They got to move. They just had a fall. They're so sore and achy, right? Not too much you can do, maybe a little Tylenol, but they do need to get out of bed and get dressed. So take a deep breath. Blow out slowly, right? We got it. And if you talk to them and walk them through it, I know it's painful, but we'll take it slowly. Some reassurance goes a long way. Yeah. Or you can pre-medicate an hour before getting out of bed, right? What else? Any other strategies that people use for pain management? Encourage them to get out of bed, get outside, get some fresh air. Especially with the chronic pain people, right? They tend to get depressed. What would you recommend for someone who has a substance abuse issues, but a history of spinal cord injury, quadriplegia, and very resistant to not taking opioids and benzos? Well, hopefully they're seeing a therapist, you know, and they are working through substance abuse issues. There are, yeah.
There's actually a case that Katie is working on here on Maui. She was going to present a little bit about it, but it's not pain focused. So I don't know if we want to wait for another time to share this situation. But specifically, yeah, he's in one of our nursing facilities, and he is not interested in therapy, but has a lot of pain and tightness.
Yeah, there are lots of muscle relaxants and things like that, and maybe work with physical therapists, a lot of stretching, and maybe, I guess you'll have to figure out, you know, what he might respond to. He's probably tried a lot of different things. Oh, yeah, medical marijuana, ointment, edibles, vape. I don't know. It depends on what you're comfortable with as a facility. I'm not going to tell you what you're going to be comfortable with. But yeah, sometimes these people are open to things like yoga, relaxing music, and even creams, things that give them a little more control. So Namaste works, yeah. So Namaste is for those who don't know, is kind of like a multi-sensory and a sensory experience to sort of help calm things down. Like a spa. Gotta understand the difference. Okay, well, I don't know the difference, so somebody else will need to share that. Have people found some of these medical marijuanas and things to help? I would say if you do go in that direction, you have to be very careful on the formulation, and to be careful in using it in older adults with cognitive impairment, because there may be some cognitive effects as well. Yeah. Pet therapy, yeah.
Definitely like that idea. Pet therapy is wonderful.
Right. And if you keep them distracted, right, with activities or something soothing and comforting and busy, and not so they're not just sitting there thinking about pain all the time, right? And they take their mind off their own self. That helps too. Keep them occupied. Great. I know that we need to have some time left for evaluation, so I'm gonna let you do that. Okay.
Thank you, Dr. Wen. Thank you everyone for attending. Please don't forget to complete your evaluation. And once you've done that, a link will be sent out to you to complete an online survey regarding medication reviews. So please try to complete that, because it helps us demonstrate that you are doing a great job. So evaluations are going to be mailed out using an automatic system. So please double check that we have the correct spelling of your names, and email addresses. Otherwise, it will go to the wrong email address. Okay, any other questions? Thank you so much.
Thank you.
Okay. Well, hang
Okay,
on for a little bit if you need. Thanks, everybody, for joining and
much.
keeping up.
Okay, bye-bye.
Oh, wait, you know what? I almost forgot. Alzheimer's Association. Are you still here?
Yes.
Okay. Do you want to share? They have a new care home support group. So I'd love you to be able to talk about it. Oh, where is it? Okay, so I don't know where they are, but I want to let you know that there is a new care home support group from the Alzheimer's Association that is going to be starting up in May. And we'd love for you guys to participate if you can. And, we'll see if we can make this work. Because what we were trying to do, because we did that survey like several months ago, and there seemed to be a need for folks to be able to just share about their challenges from caring for patients with dementia, and that it would be helpful to be able to hash that out and share ideas and things like that. So, and get a little bit of support from each other. So probably you guys be on the lookout. You'll probably be getting emails coming through in the next couple of weeks about care home support group, care home and foster home support group for dementia. So anyway, anybody have comments or questions about that?
No comment.
Okay. Great. Okay. Don't forget to fill out your evaluations.